Hello and welcome to The Breaking Point, Why Are Women Leaving the Medical Profession? I'm Ryan Grubbs, class of 2010, and co-chair, along with Marcia Eli, class of 80, of the Pembroke Center's Programs Committee of the Pembroke Center Advisory Council. On behalf of the Pembroke Center for Teaching and Research on Women and our co-sponsor, the Brown Women's Network, I'm so happy to welcome you to this evening's program. Founded in 1981, the Pembroke Center's research and teaching explores social change and how questions of difference in gender, sexuality, race, class, religion, and more affect our thinking and our world. Since its founding, the Pembroke Center has enjoyed and been strengthened by the support, engagement, and advice of a broad and dedicated community, the Friends of the Pembroke Center. The Friends are alumni/alumni, parents, and friends who support the mission of the center, and their work has helped the center impact students, scholars, members of the public, and researchers, both at Brown and beyond campus. The Friends Advisory Council organizes programs such as this one to connect communities, both alumni/alumni and wider friends with the center. Tonight, we're thrilled to welcome Dr. Sabina Holland, Dr. Valerie Parkes, class of 88, MD 92, and Dr. Wendy Wilcox, also class of 88. Unfortunately, our moderator, Shefali Luthra, class of 14, is unable to join us tonight due to illness, but has kindly shared her list of thought-provoking questions with us. We wish her a speedy recovery, and I'll be stepping in as moderator and will try to navigate the conversation as deftly as Shefali would. Before I introduce our panel, an invitation to you. After the moderated discussion, we will move to questions from the audience. We invite you to share your questions through the Q&A box at the bottom of your Zoom screen. We'll take as many as there is time for at the end of the program. With that, it's my great honor to tell you a little bit more about each of these accomplished women and invite them to wave when I do their bios on the screen. A graduate of Xavier University, Louisiana, Dr. Sabina Holland received her medical degree from Louisiana State University Health Science Center at Shreveport School of Medicine. She completed her residency in pediatrics at Orlando Health Arnold Palmer Hospital for Children, where she was selected to serve as the chief resident. She completed her fellowship training in pediatric infectious diseases at the Warren Albert Medical School, Hasbro Children's Hospital, and Women and Infants Hospital of Rhode Island. Following fellowship, Dr. Holland joined the faculty of the Albert School of Medicine, where she's an assistant professor of pediatrics in the Division of Pediatric Infectious Diseases. Dr. Holland currently serves as Associate Chair for Diversity for the Department of Pediatrics, Medical Director of the Rhode Island Pediatric HIV Program, and the Associate Program Director for the Pediatric Residency Program and the Pediatric Infectious Diseases Fellowship Program. In 2021, she was appointed to be the inaugural Assistant Dean of Medicine for the program in Liberal Medical Education's first generation and underrepresented medicine students. Dr. Valerie Parkes received both her undergraduate and medical degrees from Brown University and completed her internal medicine residency training and infectious disease fellowship at New York Hospital, Cornell University Medical Center, the Memorial Sloan Kettering Cancer Center. She joined the faculty of Icahn School of Medicine at Mount Sinai in 1997. Clinically, Dr. Parkes is an infectious disease physician and spent much of her career doing HIV medicine. She was the course director for a course entitled Arts and Science in Medicine. In this role, Dr. Parkes developed a clinical curriculum for first-year medical students, an innovative program, the Longitudinal Clinical Experience, and spearheaded the implementation of a forward-thinking clerkship in urban primary care. She's the faculty advisor for the Women in Medicine student group. For her work in medical education, Dr. Parkes has received multiple teaching awards. She currently is the Senior Associate Dean of Admissions and Recruitment for the Icahn School of Medicine at Mount Sinai. Wendy Wilcox is an obstetrician gynecologist and fellow of the American Board of Obstetrics and Gynecology. She is the Chief Women's Health Officer for New York Health and Hospitals, the largest public health system in the United States. Dr. Wilcox has been a longtime advocate for women's health and continues to lead efforts to improve health equity. She earned her MD from State University of New York Upstate Medical Center, an MPH from Columbia University, and an MBA from Wagner College. And then, although Shefali is not here with us, I would like to read her bio just because she did so much work on this leading up. But Shefali Luthra, class of 14, is an award-winning journalist who has covered national health policy for the past decade, most recently at The 19th, a nonprofit newsroom covering gender and politics. Luthra's writing has appeared in the New York Times, The Washington Post, NPR, and more. Her book, Undue Burden, Life and Death Decisions in Post-Roe America, will be published this May. And so with that, we will start our conversation. Thank you all for joining us. So I'm going to share a little intro that Shefali wrote, just sort of give some context to our conversation tonight. She says, I want to acknowledge that the topic we are addressing is incredibly broad. Why are women leaving the healthcare workforce? And that tonight we'll be addressing a slice of it, focusing specifically on the experiences of being a physician who is a woman. There are hours more discussion we could have unpacking the experience of other healthcare workers, such as nurses, physician assistants, and home healthcare workers, all professions that employ largely women and often women of color. But we'll have to save these topics for future conversations. So with that, I'll open it with the first question, which is, we'd love to hear from each of you. Could you tell us briefly about your professional journey? What did it take to get here? Dr. Holland, perhaps we could hear from you, then Dr. Wilcox, then Dr. Parkes.
Sure. It's a story that I tell quite often in my role mentoring students, but I grew up, my parents were in the military, so I spent a lot of time in different places very, very early on in my childhood. Probably in 3rd or 4th grade, I moved to Louisiana, rural Louisiana. And that's where, my sort of what we consider now formative years, especially in thinking of your college admissions, that's where that occurred. We had one high school, had one AP course my senior year that I took, calculus, but prior to that and after that, we didn't have any others. And so, I did not have, I say that to say that I didn't have a huge network of women physicians, of Black female physicians to look at, and actually stumbled upon medicine by reading. I read a book called The Hot Zone. I think they've made it a movie now by Richard Preston. It talked about Ebola before Ebola was as well known as it is in mainstream media. And I as a 12 or 13-year-old, I said, that's what I want to do. I was completely and utterly fascinated. I thought I was going to do internal medicine, actually, and ended up in pediatrics. But it's because I read a book, not because I had any sort of mentor or anyone, to look up to. In fact, I went into my high school counselor's office and said, I'm going to be a doctor. I'm going to go to college. This is what I have to do. And they said, okay. And that was about it. There was no direction in terms of which college to go to. I was all about going to college. I got a postcard from Xavier, University of Louisiana, that said that they are the #1 college in the state, in the United States, at getting African-American students into medical school. And because I got that postcard, that's where I went to college, because I was going to medical school. It was as simple as that. I went to LSU because that's where I got in. And I think, my underlying it all, I guess, is a little bit of grit, perseverance, some stupidity, because I had no idea what I was getting myself into. But really, it was the passion for infectious diseases that drove me.
Perfect. Thank you.
Hi, good evening, everyone, and thank you for asking that question. So I was born in Brooklyn, New York, and I was raised right outside New York City in Westchester. My parents moved when I was about kindergarten. I grew up in a small town called Hastings-on-Hudson, which is in Westchester County. And I attended school there in that community from kindergarten through 12th grade. I don't remember how or why I wanted to become a doctor. I'm sure it was kind of a thought implanted in me by my grandmother and my parents. But I do remember a little play school hospital set that I used to love as a kid. So perhaps that's how my desire to be a doctor came about. I attended Brown. My dad actually had gone to Dartmouth, and so I was kind of well aware of all the hospitals, all the colleges in the Northeast. And so did the tour, went to Brown's weekend, loved it, and was like, okay, I found my tribe. This is where I'm going. So I did major in biomedical ethics, which is no longer concentration, I found out, because I'm also a P23 of a daughter who just graduated. But I was at that point gonna kind of hedge my bets. And so I figured half the people who went for this concentration either went to medical school or law school, either of which would have been okay. So I, throughout college, I was still like, do I really want to be a doctor? Maybe not, maybe I do. After graduating, I did decide to pursue medicine. I attended our state university in Syracuse, SUNY Upstate. Then from my rotations, decided that OBGYN was one of those really interesting specialties, because I think what attracted me to it is that you're kind of in 3 different areas in a hospital. You're not always in an office. You're not always on the inpatient hospital setting. You can also be in an OR. And interestingly enough, some of my best friends at Brown also became OBGYNs. And we definitely had a support group. My career journey, I am the system lead for obstetrics and gynecology, also known as the Chief Women's Health Officer for New York City Health and Hospitals. For those of you outside of the New York area, we have 11 hospitals in the New York City area, all of which actually, interestingly enough, have labor and delivery suites and our maternity hospitals. So in addition to the gynecology portion, that's kind of my purview. But you also did notice all those extra letters after my name, or all those extra degrees. So after my first job, really after residency, I was at a clinic in the South Bronx, and I started to see a pattern. Pretty much every patient I was seeing almost looked the same. It was really interesting to me, the challenges with each patient. And I started to really think, am I really being the most effective that I can be, seeing these patients one after another, kind of doing the same thing with the same challenges? And I started to really become interested in public health. So I was one of those people who got my public health degree after I had already become an attending physician. I don't know how I did it with 2 toddlers and a full-time job, but I attended the Columbia Executive Program Mailman School and got my MPH there. And that's when I really started to think about population health and how could I best effectuate things there. So after that, I was a clinical attending physician, and I became leader of my group in my first job. And then I kind of started to become interested in leadership. I was vice chair of 2 hospitals after that, and then I was chair of a department in Brooklyn, and now I serve as the system lead. So we can get into that later, but definitely I think I've found a career in clinical medicine and public health, and as you heard from the intro, have an interest in disparities in health, in maternal health and child health, and really work on those things pretty much every day. Thank you.
Perfect. Thank you so much. Dr. Parkes?
Yes, hi, thanks. Thanks for having me, and thanks to everyone who's come on the webinar. I'm Valerie Parkes. I grew up in New York City and went to Brown University, as you all are probably also did. And I think I never totally admitted to myself through college that I was pre-med. In other words, I kept taking the pre-med courses. I majored in something called Health and Society, which I think does not exist any longer, but was really public health. And I knew I was interested in healthcare delivery, but I think I was a little bit scared to sort of just say out loud, I want to go to medical school. And ultimately, I ended up going to Brown for medical school and going straight through from undergrad to med school, which is a bit of a story that I can tell maybe later. Because it wasn't exactly the PLME, but it was sort of the year prior to that. I wrote my thesis for my concentration in women and HIV. And so, from a public health perspective, and I think that really sort of set the stage. I ended up going into internal medicine and then infectious diseases. And I think a lot of what pushed me in that direction was really what was happening around the world, sort of the history of medicine that was unfolding as we were training. I trained in New York City in internal medicine, and many of the people from my year in internal medicine did an infectious disease fellowship. There was just, we were in the midst of the HIV epidemic and folks needed care. And I think in some small way, many of us felt we could humbly make a difference. And so that really was the bulk of my clinical career. I will say that I did not know that was what I was going to go into when I started medical school. I had been a varsity athlete at Brown, and I thought I would go into orthopedic surgery. And you pick a field for a multitude of reasons. And I ended up really feeling very passionate about internal medicine, infectious disease, and immunocompromised hosts, and HIV particularly. My career, I think that my generation wasn't as aware, at least I wasn't as aware of sort of all the different paths within medicine. And so I started teaching early on, teaching residents, teaching fellows, and ultimately teaching medical school students at Icahn School of Medicine. And around that time, there was sort of an important piece written about clinician educators, and that it should be a promotion track, that it should be a track of getting promoted. It had really never been prior. And so I think people now often will think about the fact that they want to teach and do medicine and they want to be a clinician educator, but I don't think that was even part of my repertoire of knowledge. But slowly I sort of realized that that's what I was becoming. I was a course director in a med school course, and ultimately ended up doing that for a lot of my career for like 10 years, developing curriculum, thinking about pedagogy and teaching. And then moved over to admissions, still thinking deeply about, had spent a lot of time thinking about how we teach and how we teach patient-centered care and how we think about family-centered care and thinking about, the theme of patient as person instead of patient as illness, and really deeply thinking about all of clinical care and how we teach it. And then I sort of moved over to thinking about who we teach, and really, really deeply invested in broadening access to medical education, broadening diversity in all realms for the medical school students and therefore for the workforce. So sort of pivoting, but evolving from how we teach to who we teach. And so I think that clearly also impacts healthcare outcomes about who's in the physician workforce. So I've been doing admissions at Icahn for, I think, close to 15 years. And so I'm happy to be here and happy to talk with all of you. Thanks for inviting me.
Terrific. Before we go to the next question, I'll say, Dr. Holland, The Hot Zone was one of my favorite books as a child as well. It's an excellent read if you've not read it. Sadly, I did not go into medicine, but it is an excellent read. So our next question, we know that women are more likely to matriculate into medical education than men, but we also know that women graduate at lower rates and are less likely to be represented in positions of leadership. And this is especially true for women of color, and specifically physicians who are Black women and Latina. What are some of the phenomena at play here? What is happening between the matriculation stage and everything else? I think Dr. Holland and Dr. Parkes, if you want to take first stabs, but Dr. Wilcox, please also weigh in as well.
Sure. I think there are so many things. In anticipation of this event, I asked one of the deans at AM, asked Dr. Breeze to what's happened in the PLEMI in the last 10 or so years, and I think I'm pleased to say that the matriculation rate for women is like you said, it's fantastic. The graduation rate, at least from 2015 beyond, is also in the high 90%. But something happens between the graduation and either going to completing residency and entering the workforce. And I think that, as you mentioned, it's a myriad of things. Life is also happening, right? We are finding partners, we are deciding whether or not we want to have children, and if so, when, right? It definitely, for me, I could not have had a child in residency. I expertly planned my children to happen during my chief year, my final year of fellowship. And then after I had been in attending for a certain amount of time, and even at that point, it felt like pure chaos. Because when do you have time to take off from work, come back? If you choose to breastfeed, how do you do that? There are so many life logistical issues, and that doesn't even incorporate, the harassment, the difference in pay, the fact that, you may not see somebody who is your same gender or race, ethnicity, in a leadership role, if that's what you're interested in. So I think the topic is broad. I think every person or every woman has a different story in terms of the challenges they faced, and whether or not they've decided that medicine still brings them the joy that it initially did, enough at least for them to stay.
I think that the question is, like all questions, probably complicated and multifactorial. I think that also on this call are 3 women in academic medicine. So I think we do need to sort of also take a step back, because first of all, I think women are applying to medical school, they're matriculating into medical school. Across the country, the percent of folks who matriculate and then graduate is extraordinarily high, right? And so they are by and large graduating from medical school, because by and large, with nurturing and with support, folks who get into medical school graduate from medical school. I think that what becomes complicated is there are a lot of different jobs, and perhaps what we're talking about and thinking about, because the data is clearer, is academic medicine. And so if you look at the data, if you look at chair people or deans or the dean, right? And go down from professor to associate professor to assistant professor, right? There are more women as instructors and assistant professors, and it becomes less as the funnel sort of goes up. I remember a call out at my institution for the gender equity dean, and one needed to be a professor to become the gender equity dean. And I wrote sort of probably a snarky text to a friend of mine, like, well, by definition, there aren't that many people in each department that are women that can become, who are professors who can apply. I mean, that's the problem, right? We're like doing a circular thinking here. And I think that is for a multitude of reasons that Sabina has talked about. Life becomes complicated. There is a sense in the chaos of it all that you're doing everything sort of 50% or 60% or 70%, but we're folks who want to do things like 150%, right? And so if you feel that on both ends, at work and at home, think you're not doing your best stuff, you sort of pull away. And there are a lot of other, I think there are also one message is that, yes, there's a lot we have to fix, but also there are a lot of paths with an MD, right? And so one can be a full-time clinician, or one can do policy work or education work or writing or consulting or biotech or whatever. So I think there's a lot of places that we can fix this, but I think we also need to, despite the title of today's webinar, we also have to stay a little bit optimistic, because there are a lot of paths and there is a lot of time, and one can redefine oneself a number of different times. And so I think we have to hold on to some of the nuggets of really thinking about how we can do this and make sure that we're able to support young people in all their endeavors. So I think that Sabina, I want to amplify a lot of what she said. It does get complicated and hard, and I'm still trying to imagine Wendy doing the MPH with 2 little kids, because and the MD full-time job. So there you go. It's hard, but we can do it with the support and some policies put in place that are maybe future ones. So
Yeah, no, I totally just want to put a pin in what you said. I mean, I totally agree with what both of you have said. Actually, I just don't remember a lot. It's all a big blur, so I don't know. But no, what Dr. Parkes just said is absolutely true. I believe this is the first, couple of years ago, this was the first medical school class where a majority of the entering class stated that they did not intend to have this as their only job. Like they entered medicine knowing that they were going to leave. And that makes sense because there are a lot of other career paths with an MD degree. And we're finding them, right? People are finding them and finding different pathways. I just recently came from the Brown all class Black reunion, and one of my classmates who had been an orthopedic surgeon is now in banking. And I said, what? He said, yeah, he's an investment banker. So you know, minds have shifted. People are much more aware of their mental health and the balance that doesn't exist, which is the work-life balance that we all as a myth continue to propagate. But people are much more concerned about getting what they need out of life and making sure that their priorities are met and recognizing that. I was actually talking to another physician over the weekend who was kind of sort of asking for some advice. And there was a role opening up at her institution for, I think it was associate dean. And she was like, well, should I go with that? And I said, sure, absolutely. If that's the pathway you want to go for it. And she said, well, it's going to make me go to the other campus. And I said, oh, well, you know, parking's not as good there, but sure. And then she said, well, I'm 0.3 now, and that's going to require 0.5 of clinical. So it would actually increase her clinical, make her life more cumbersome by like the parking issues and making her drive farther from her house. And there was no guarantee that the pay was any better, right? So should she have gone for this, you know, promotion, or was she really thinking about what makes me happy? And yeah, she'll find something else down the road. So I think that's where we left it. But I do think that people are confronted with these decisions every day and throughout their careers. And this is what influences a lot of the decisions.
Great. And we've touched on these in just the past couple of minutes, but like structurally, what do you think are these biggest barriers for women to advance in medicine? Is it a lack of childcare, mentorship, implicit bias? And like, do you have any thoughts on how one can address these and sort of affect change? I know, Dr. Parkes, you said there might be some future policy things that could maybe come down the line, but in your thoughts or opinions, what are these kind of structural barriers, and are there steps to kind of maybe address them?
yeah, and I'll start, and then I'm sure everyone has other ideas as well. I do think that for people who choose to have families, I do think that childcare is extraordinarily important, and parental leave is extraordinarily important. I think those are policies that we can do, and we can do better, right? So that because I think if you feel chaotic and you feel like you're not doing it well, you feel less happy, and so you feel less satisfied in your career, and then you look for a change. I think that support for, if you're trying to get promoted, support for sort of some delay, and acknowledging that there's going to be years where, if you're running to parent teacher or getting to daycare on time, or, for me, soccer and baseball and lacrosse or whatever, right? Then you're not writing and researching. And so again, it might take some time. And I think that the mindset that that's okay, that this is a bit more of a marathon than a sprint is sort of a mindset. I think pay equality and having champions at your, at your in your field that make sure that that is the case, so you don't feel the sort of level of distrust. I think some things, there's some data and everyone has a different personality, but I think that I have friends who I literally walk by the hall and I'm like, say no, repeat after me, say no. Because there is something where, oh, I feel honored to be on that committee. And so you're doing sort of that unpaid work. And perhaps it's easier for others to say no. So I think that is, there is some literature. I don't want to stereotype, but I do think women have a little trouble saying that. So we end up doing some, unpaid work in the work. I think that there's other policies. I think that probably explicit mentorship. And I think when that's not available, having mentors and having folks that really are, not only telling you, kind of giving you advice, but also championing you. That's not such a good word, but you know what I mean? It's really helpful. And I have found that peer advice, like peer mentorship, like having a cohort to hold myself accountable in sort of a casual, friendly way is really, really, really helpful. And so I feel that there's sometimes folks who are on my phone call on the way home from work or whatever, where we just check in. And I do think, in addition, and then I'll stop talking, I promise, learning. I do think there is some credibility to the fact that sometimes it's hard to be the leader, not be seen as overly aggressive or somehow not friendly, or maybe on the opposite side, too emotional. Like, I do think these biases are present, and and they do impact us, right? And so I think that's unconscious bias training. That's teaching everyone. That's teaching yourself. That's education for everyone. And I think we can do that. And we are doing it.
Yeah, I just want to, highlight that. I think that medicine is completely late to the game, so to speak, when you talk about addressing bias and the isms, racism, sexism, ageism. We are just now getting to it. And the Fortune 500 companies have been doing this for decades. In hospitals in Rhode Island, we are still trying to find places where women can pump breast milk, let alone have time to, set aside to pump breast milk. That's not mentioning anything about maternity leave. We are still fighting for pay equity. It's 2023. Like, that should be, we shouldn't be having that. We shouldn't be having this conversation, as it stands. But there are some very basic things that I think medicine, as a whole, needs to really sink its teeth into, so to speak.
So my two colleagues here are amazing, and they are being so good and so controlled. I think the system is designed to produce the results exactly that it is producing. Okay, we live in a society that may be interpreted as sexist, as evidenced by the gender pay gap. There was recently an article a couple of years ago about how women over the course of a 40-year career will earn $2 million, that's $1 million less than their male counterparts. You can't tell me that's by accident. Okay, you can't tell me that the lack of women and women of color in pretty much any position of leadership that you can think of, dean, associate dean, chair, hospital leader, whatever leadership position you were talking about, there might be about 4% women out of the entire group. It differs maybe by a percentage point or not. And so we're coming from a system where women outnumber men for matriculation, in medical school, something happens where we drop slightly for graduation. And then so somehow over the course of our careers, we manage to earn less and never quite reach the same equity in terms of achieving leadership. I don't think that's by accident. And so what could fix that? Some real honest discussions, some policies, some things that actually protect maternity leave, paid maternity leave, and respect the fact that you, like many other countries do, can leave the workforce and or take time off and still have a brain to think when you get back and do a damn good job. I think that, you know, so many of us are, yes, maybe doing the unpaid work, right? The committee tax, the this tax, the mentoring tax, the blah, blah, blah. But you know what? You have to be really smart and have a good head on your shoulders in order to do that. And we still do it. And manage to, you know, if that's our choice, raise families and do everything else too. Medicine is late to the game. I completely agree with Dr. Holland, and you know, hopefully for future generations of female physicians and doctors, maybe we won't have it totally fixed, but hopefully the work that the three of us are doing now will have some impact, and so it'll be a little bit better. Let's hope.
Great. And sort of dovetailing off of that, from your own personal experiences, what were the biggest challenges to you staying in medicine? Were there moments you considered leaving or trade-offs you had to make to continue in the field?
You want me to answer?
Whoever wants to go first.
Go ahead. We'll go in reverse order.
Okay. Wow. So my first job, I will not say the institution, was at a large medical system here in New York City, with a scary chairman. And when I say scary, everybody kind of was in awe of him and a little bit frightened, who everyone knew paid women less, disrespected us. And, you know, I mean, just, it was like an open secret. I, in that job, became incredibly frustrated. I was there for 10 years. I would say year 5 is probably when I ended up getting my MPH. And I did have my first leadership position there, which was as leader of my group. But I started to grow increasingly frustrated because I just felt like I wasn't moving anywhere. And I knew that if I stayed, I just wasn't going to be able to move anywhere. It turned out that the person who was chairperson stayed for a really long time in that position, like 30 years. And when you have that person staying for such a long time, nobody moves, right? Because the person at the top isn't moving. So there's not any room for, unless you expand laterally, which is a limit to what can happen. So, I think that with my MPH and knowing that there were other types of opportunities out there, there was a huge part of me that was thinking about other ways to use my MD degree that did not involve really medicine as a career. However, I stuck it out and I managed at that point to switch over to New York City Health and Hospitals. As I said, not in the role I am in now, but in a different role that kind of just helped to let me see that, you know, I could have some forward movement. I was kind of stuck geographically. My husband at the time was a judge, a state judge. And so if you know anything, you can't really move. And, you know, we all live in these communities where you kind of know what you know, right? There's not really a lot of latitude in terms of different places you can go. So I felt lucky to have been able to gotten the position that I got. And then as we see, I've been able to move up through my organization and And so I am satisfied with where I am now, but things were looking kind of dicey for a while. And I really was thinking like, do I really want to keep banging my head against this wall? So, that's my story.
I can say I've not considered leaving medicine. But as I say that, let me say that my chair is a Black female. My direct, like many of my direct reports have also been minority females. And so I am here at Brown, even though my entire family is Southern and my husband thinks that snow like is incompatible with human life. Because I recognize the unusual unicorn ecosystem that I am in. And so I am here because of that. You know, that's not to say that I haven't had issues with pay equity. And thankfully I feel empowered enough to, you know, to bring those to my chair, you know, where we can discuss them and remedy that. You know, and so I do feel like I am in this like wonderful bubble, where I try to actually recruit other people because it's such a unique and different environment, far different than what I experienced when I was in residency. Even though I was a resident, seeing what other female attendings were going through, and in medical school. And so I know the ecosystem that I'm in. I also, you know, my chair, like I said, she is a woman, she has children, she understands, you know, what it's like to be an attending and have children. And so, you know, my division director, although he's a white male, he is incredibly empathetic, and knows, you know, he has children himself. He's married to a female physician. And so I feel lucky in that way. And I really love my job. So I love PDID. You know, I will say that it took me a while, probably longer than most, to really understand what being in academia means and the importance of being in academia, and why I should care that I'm being promoted. And I think that's, you know, that's something that we can also talk about, is that I didn't see the value, in being promoted and being recognized for the work that I do. And that in and of itself is a problem. But I feel lucky, and I feel like I want to say that over and over and over again, so that everyone listening, you know, can think about who they are promoting. Because I feel like I can, you know, I can advance and be supportive and be the best Sabina that I can be, because I have support of people who understand what it's like to be a woman in medicine.
So I think that the times in my career that I felt perhaps less fulfilled or more frantic or something, probably when my kids were young. I was you know, I was a junior attending. I just became an attending. Actually came to my first job pregnant, which was not really taken so well from the people who recruited me, but such is life. And then had a kid pretty quickly, another kid pretty quickly after that. My kids are 2 years apart. And I think it felt hard on the home front. At the same time was when I did start more teaching, and ultimately got offered the position to be a course director in the medical school. And the balance of having sort of 50% education and 50% clinical, when my husband is 100% clinical, really, I think helped us, because I suddenly was not as frustrated. I could do some curriculum stuff after the kids went to sleep. Like, I'm not saying that I went into education for that reason at all, but it did suddenly somehow give me a little bit more maneuvering ability. And I do think that kind of just helped my outlook. So I again, back to sort of thinking about opportunities, having people champion you, having people supporting you, and thinking about different pathways. I think I was a better clinician. Again, it was HIV medicine early on. It was really hard, and people were dying. And I think that, you know, I doing that really, really well, but half the time was better, because it's never really half the time, but it was just a little bit better. And I think I did better care in that way. And so, and then the education I was then having a chance to be with medical students who, of course, keep you young and keep you ideal, you know, keep you both realistic, but also they are inspiring. And they're going into medicine for the correct reasons, and it keeps your day fresh. So I think that was really, really helpful. I do also think, despite the fact that Sabina's husband doesn't like snow and her family's in the South, I have been privileged, and I think that to be near family, and I do think that's been very helpful. And of course, having inspiring role models, and you can build friends who become family wherever you are. And so it doesn't have to be, you know, it's chosen family, it's real, it's family, it's all good. But that support system outside of medicine, so that you can say, can you grab the kid from school? Because I am running late and I'll do it for you tomorrow. Like, that is good. And also, you know, I think you want to be there for the things in your life, whatever they are. If you choose to have kids, or you know, you're involved with some organizations or whatever, those things that keep you whole require your attention, and you want to do them. And so allowing yourself that grace, right? I think it took me a very long time to get promoted, and that's okay. As long as I was taking good care of my patients, like, it's okay. It's all okay. And so I think those things, just kind of giving yourself the grace to do it your way, is really important.
Terrific. Another question. The COVID-19 pandemic has wreaked havoc on physicians of all specialties, and a particular burden on working moms. From your experience, or from that of peers, do you see any continued fallout? Has the pandemic undercut efforts to keep women in medicine and to help them advance? I can think also this might be something to talk about with the academic track too. So I'm in education, and, you know, the tenure clock for women faculty with COVID, there's a whole, it's all messed up now. And so, yeah, what have you seen in your own experiences or from peers vis-a-vis the COVID-19 pandemic and women in healthcare?
I'll go first. I don't have a ton to say. I have to say that, you know, we are all experiencing a nursing shortage, right? Because all of our nurses who could retire did. That would also go for the physicians who are able to retire. And, you know, I still think that people are tired. They may not realize that they're tired, but we all just kind of went through this big stressor, and then we tried to go ahead and carry on with life as if nothing really happened. And so we're all just trying to move past the moment. I am not convinced that there's any particular fallout from COVID for specifically women, other than to say that I think, you know, the physician burnout as a whole is still there, and kind of underneath the surface, and people are working short-staffed, especially in the mental health areas. There just aren't enough behavioral health providers to go around to fill all the gaps, including probably for healthcare professionals. And so I just really see it kind of as an overall challenge for all physicians, not necessarily specifically for women. Although I will say that my kids are older, right? I have a son who graduated you know, in 21, and a daughter who graduated in 23. I do not know what I would have done if I had to deal with children trying to learn at home. I actually
Exactly.
think I probably would have like
That's the
stopped my brain.
thing.
So
I
I'm
think
like,
that's
God
probably
bless
the thing.
everybody who went through that, because that physician or not, like, I don't even know how people did that. I don't know.
Yeah, no, I was going to comment on that exactly. And I also have a very unicorn situation where I was stay at home, like my husband is a stay at home dad. He did the learning I could not have. When I am home, I am mommy, and that's the way that I've set it up. And so, COVID was challenging for me because I never got my like home office set up. Thankfully, I'm a pediatrician, so usually the meetings that I'm on, it's not uncommon to have a child or two or three decide to pop in or Zoom bomb my meeting. And so, from my perspective, all of my meetings, I try to at least have them happen at home. That being said, colleagues, especially those, as you mentioned, tenure track, especially my colleagues who are on a research track, it was incredibly challenging for them to manage, research and what's going on with their research projects and trying to navigate virtual school and all of the ups and downs that come with it. And that's not even speaking to the stress just innately from dealing with a pandemic of that proportion.
Yeah. So I guess just to amplify what was said, and I do think that the burnout from just the stress of being a physician in a pandemic, I think that there were just, there's just so many months of sort of waking up, just this sense of, I sort of felt like my heart rate was like elevated for like a year, and that felt different for me in a way. And so, and that's probably not unique. There was just, and so I think we all have kind of like, we're now getting back to normal, but perhaps again, didn't give ourselves the moment to sort of think through what just happened there. You just kind of realize you got to go, and you just go. And so it was stressful. I agree that my kids were older, so in some way, I oddly got more time with them, which, I feel horrible saying like that was kind of this wonderful thing that happened. I mean, that's a weird thing to say, but I think it definitely cut across. And so I don't think I can speak to, there were folks, I mean, at home with homeschool and 2 jobs and not enough room and people on Wi-Fi and lack of learning. And, so I don't think that I can do that justice. But that is a real thing, and that impacted women more than men.
Definitely.
I have about 1 or 2 more questions, but I'm going to encourage those in the audience to start submitting your questions using the Q&A function. But I'm going to ask a very obvious question, and that is, why is it important to pursue gender equity in medicine?
So I am a very concrete thinker. And like the first thing that came to mind is because it's the right thing to do. I can come up with something more eloquent and elaborate, but that's what came to mind as soon as you asked the question.
I mean, I think equity in medicine is almost the most of moral imperative of any field in the world, because it clearly has to do with healthcare outcomes and disparities in healthcare outcomes. So, taking care of women, taking care of folks who are underserved, underrepresented. I think that I feel that equity in general in medicine and who is represented in medicine and how we elevate voices in medicine has to do with medical outcomes for people in our cities, in our rural parts, globally. And so it feels very clear to me.
Totally agree with both of my colleagues. And I would just say, you know, because it'll help families, right? Because women are in medicine, we're in the majority of some of the professions, and, you know, shorting all the women in medicine $2 million over a lifetime is not helping society.
So good answers.
And we have
Uh,
excellent
okay.
patient satisfaction scores, since that's a big thing
Yeah,
now.
absolutely. I mean, because we deserve it.
And better outcomes for chronic illnesses.
Exactly.
Absolutely.
So my last question before we turn to questions to the audience is, if you have any advice for young women in particular who are thinking about pursuing medicine.
I'll start. Don't give up. Just don't give up. Just stick-to-itiveness, perseverance, whatever it takes. You can do it. Believe in yourself. If you need a little more time, take it. Don't drive yourself crazy. If it's really not what you want to do, then absolutely not. But if it is something that you want to do, please just know that you will finish, you will be successful. Just give yourself the leeway and the grace to do that.
Yeah, I would echo that. I would say find your joy and give yourself grace. And seek mentorship. Don't be afraid to use your mentors. It's probably the most helpful bit of advice that I've gotten is use your mentors. Don't be afraid to ask for help, ask what they did. Because, you know, we all want to share, and we want them to succeed.
I agree with using your mentors. I also really, really believe in this peer mentorship. I think find your people and they will have your back and hold each other a bit accountable, and also, you know, give each other a little grace. But I think that really, really helps. I think also don't feel stuck. I think that some of the burnout occurs because you're so far down a path and you can't, oh, you did all this already and you have debt and you now go do it. And all of a sudden life is complicated and maybe there's kids now and you're not stuck. There's this, you know, we want you to be clinicians because that's where we need folks. And there are other opportunities to leverage the degree, but also there's other ways of putting together, right? You can do part-time clinical for some years and then re-enter later and expand or get another degree or whatever it is. It can be again, it's a marathon. And then lastly, not that everyone chooses to have children, but I do think they end up proud of you. I really think, I mean, in a lot of fields, but in this one too. And they end up kind of like wanting to do something impactful. I think that's lovely, right? So I think you're a mentor, you find mentors, but you're also a role model and you're a role model for them. And I think that you don't want to miss any time with them. And so you work your schedule around not missing it, but also they know that you're doing good stuff when you go to do it. And I think that's really important.
Right. I think that's, you know, that's one of the things that I at least try to do with my kids is, you know, if I do have to miss something because I'm at work and they ask for why, and I love being able to tell them because I love my job and it makes me happy. And that answer makes them happy.
So that's
Also,
why my
taking
kids
care
don't
of
want to be
sick
doctors.
kids. Say it again.
I said, so that's why my kids don't want to be doctors.
Mine are not doctors either.
None of mine are interested yet either.
You got to get them reading the hot zone. See if that.
I
will
know,
work.
right? I did want to just say one thing, which is that don't put yourself in a box when looking for mentors. You know, when I looked around as a young physician and I didn't see anybody who looked like me, and that was okay. You know, one of my earliest mentor was a nurse leader who happened to be a Black female she was the CNO, and then she became the COO, and then she became the head of a couple of hospitals. And she and I are still great friends to this day. Still keep in touch with her. But she was, you know, she was a fabulous mentor. She listened, she gave me encouragement. And so it, you know, that I don't want to say anyone can be a mentor, but anyone can be your mentor, you know, you can just, doesn't necessarily have to be a physician and doesn't necessarily have to be a physician in your specialty.
Yeah, I haven't thought about that lately. Thank you for bringing that up. One of my early mentors was a educator in geriatrics, and I'm in infectious disease, but I was going through this education track, and I didn't really have. It was really, really helpful. I really, I felt I very much benefited from her wisdom.
Great. So we have a few questions coming in from the audience. Still continue to encourage folks to submit theirs. But first question I'll ask is, as medicine becomes more corporatized with a greater emphasis on productivity measures rather than the time it takes to provide patient-centered clinical care, what impact do you think that this plays in women's experience in medicine, whether or not it contributes to them maybe wanting to leave? If you could speak on that from your experience or from experience of your peers.
I think that does put more pressure on people. I think that does, in a lot of ways, can make medicine less satisfying. Sorry about that. My dog just woke up. I mean, the bottom line is you're going to put yourself in a situation, that's not where you're not going to be miserable, right? I mean, if you're in that situation and that really is something you have to do, then perhaps it's time to look at another position.
Yeah, I would echo that. I think that, at least for me, what brings me joy in medicine is providing excellent patient care. And if I ever were in a situation where I didn't think that I could provide that care because I'm being pushed to see more and more patients, that would be a time where I would, think that it's not working for me. I'd never want to feel like I wasn't able to provide excellent care, which is different than me talking, because I am a talker and I like my patients to be able to talk to me. So I think that, like shortening my talking, but providing clinical care that is what I feel like the patient deserves, I think would be how I would center that rather than thinking of metrics. And I say that realizing that that I am in academic medicine, and so it's a little bit different. And I'm also an ID, so it's different than if I were in a private practice pediatrics or something similar.
I think that is a problem in medicine that I'm not sure has to do with gender. I think that we need to elevate our voices as physicians. I think that's why we need folks who are physicians, in leadership roles like Wendy is. We need folks who are physicians who also have a business background, a healthcare administration background, different models of delivering healthcare using technology. Like that is a problem. And so we need to, just for everyone, make the EMR more, easy to work with. Like I think we need to find our voice a little bit. So I will say that my husband is also a physician, and he did make changes in sort of the delivery model, going from full-time faculty to private practice at a point when our kids were younger. And I think it was largely more satisfying for him, and he felt as if the care he was delivering, he could do better. And so in that other model. So in other words, you do have to sometimes make changes.
Great. And I'm going to ask this question, and I'm going to try to link it to something else that I don't know if the person who asked the question their intent, but we'll see how it goes. So this person is interested in the role of unionizing for physicians, and then I wonder if there's any correlation between that and a policy step or a way to address the pay equity gap that you all kind of spoke at earlier. Is a stronger unionized practice between physicians a way to kind of bridge that pay gap, or are there other roles that a union for physicians can help, especially with women in healthcare?
I still think that there are issues, so sorry about that, with pay equity, even with unions. All of our physicians are unionized. That does bring in a whole host of other considerations that need to be taken into account. So I'm not sure just having the union alone is going to solve that problem.
That makes sense to me. I asked the question wanting to learn myself, so it's good to know. Another question is, how do you all personally practice intersectionality within your work?
That question is a little hard. Because I think that it's hard because I'm not exactly sure what what the person is wanting from it. I think that in terms of intersectionality, we all have lots of different identities, and we bring those into the care that we provide patients. I think that it becomes very hard to sort of segregate yourself, especially, I have many different roles, from education to advising, to, providing care for a patient population that's been historically marginalized and stigmatized. And so I bring all of that into each patient encounter that I have. And I try to be aware of that when I do that. And I also try to teach that to the trainees that I am working with. And I feel like I'm not answering the question that the person was asking.
No, I think that was a good answer. Another question that sort of relates to what we were talking about earlier. What efforts are being made today to embed satisfactory parental leave into practice? This person says, as a senior surgeon over the years, I've met several women trainees who have piled fellowships onto residencies and realized that they're 40 and forgot to have the baby. And now, where are they?
Yeah, I mean, I think that there's a bunch of issues there. I think some is sort of culture and climate of different places, different specialties. I think it's getting, I think it's getting easier to just sort of say that you're pregnant and be pregnant and have a parental leave during training than it was back in the day. I don't think that it's true that what I just said is totally true in every specialty and across every hospital in every region. So that's going to be different. But I do think we're moving in that direction. I think that, I mean, even just sick leave, which is not the same thing at all. I mean, we didn't have like a resident that was on sick call when we did it. Like you just weren't sick, period. So I think things are getting better. I think that in med school and then we talked about residencies a little bit. I think that it's getting better. It's not fast enough. It's not where it needs to be. I think still as an attending, I certainly had to take disability and in order to get maternity leave, and I still thank this one administrator back in the day who had just had a baby for my second child, and she just sort of circled the form and gave me more weeks than I deserved. And I was so happy that I could take more time with my second child. So, but we're not where we need to be, but I think there are voices, and it is a discussion, and it's slowly getting better. It has to move faster.
Can I just add, I think that medicine is not unique in that position, right? There are so many women in this country who don't get paid maternity leave, medicine included. And so one of the answers is maybe, you know, to push outside of our specialty. I mean, it's such a societal problem. You know, even in New York City, we're talking about like city workers. I brought up that, you know, because our attendings for our New York City health and hospitals are still buying their maternity leave. I mean, I just think it is such a societal and cultural problem that just needs to be addressed across the board.
Right. Better in other countries.
Great. Do you all think that there are other models of employment that we can advocate for that can address the burnout of physicians, especially those female healthcare workers?
Models of employment feels a little bit opaque to me. I mean, I think that there are other careers that we've talked about. There are clinical careers, you know, where there's more use of telemedicine. I think that there are, you know, practices in, you know, now hospitalists, or just, you know, doing more outpatient, so you're not following your inpatients into. I mean, there are ways that are things, and they're not going to necessarily be your thing forever, right? Depending on what the pressures are and the responsibilities are, right? From childcare to taking care of your own parents, you know, which is something that I'm facing. You know, there are different things that you need at different times. So I think that is okay. I think it's important to keep your skills up, because then you get all in your head about doing it, because this is medicine, and you need to do it well. So, but I think keeping those skills up, and if you do something a little different for some years, right, urgent care or whatever it is, then I think that locum tenens, some people do that sort of thing where, you know, maybe someone where they're able to sort of do bursts of medicine and then bursts at home, and maybe their partner does something, you know, I mean, you come up with your way, I think, with the people who are your support system.
Yeah, I agree. I think there are lots of different models of employment. I think that it really speaks to what you need, and being okay, you know, for instance, taking a break from you know, a full-time position and going part-time, and being true to that part-time, right? Because often women will say that they're part-time and work a full-time FTE. So, you know,
And they're just paid part-time.
Exactly. So I think that the real question, we are all, you know, somewhat overachievers just by nature of being in this craft. And so I think being okay with going into a mode of employment, so doing locums, for instance, because you want to work only X amount of days per week, like that is fine if that meets your needs at the moment.
I'll also say that recognizing if you need help,
Right.
and asking for it. I know Dr. Holland described that her husband is a stay-at-home dad. That I'm sure is helpful and reassuring to you as you try to raise your family. If that is not an option, you know, making sure that you have someone who you trust, who can be maybe a super nanny, right? So they're going to drive the kids, they're going to not just take care of it, but, you know, like, or parsing it out to aunties and friends, etc. You know, I just remember, I mean, nowadays this is so taken for granted that food gets delivered, but, you know, when I was going to get my MPH and you're asking, how did I do it? I honestly don't know, but I do remember I signed up for like a dairy delivery service, right? So like at a basic level, we wouldn't run out of like bread, milk, and orange juice, something like that. So,
Oh, yeah.
you know,
Fresh
just
Direct
getting help.
changed my life.
Yeah, just getting help where you can, maybe it's something like, you know, having someone cook for you, like, because you don't want to go out for meals or buy fast food, but like if there's someone who you can pay, you know, they even have services like that now, you know, like just recognizing what you need help with. I often said, I need a wife, right? Because, you know, because we as women tend to take on more in our home lives as well as our work lives. They've actually done studies of that. And so maybe trying to give up some of the extra stuff you've taken on in the home life will actually make you have more time in the work life. And
And
not
if you
something
need
crazy.
help doing that, there's support for that. So there's coaching in preparation for this role or this panelist position. I was linked to Pink Coat MD, which was set up for women that are struggling in medicine. You know, and they have a wealth of things available, including, you know, like coaching and something as simple as like you can say no, which I now, we had a junior faculty member join. I told her, don't sign up for anything without at least talking to somebody else in the division, because the pressure is insane. You want to say yes. And maybe you shouldn't. So sorry for cutting you off.
That's fine. I totally agree with what you said. Thank you.
From your experience and from what you've seen from the experience of your colleagues, are there any specific specialties within medicine that seem particularly supportive for female physicians, or conversely, specialties that are particularly difficult and or toxic for female physicians?
Ah,
I wish I could say that pediatrics was wonderful. It's not. We probably are, again, it's institution specific, right? Like I think that, you know, we try to, you know, at my institution, they're trying, you know, I know where lactation rooms should be, should being the operative word. You know, I think that, you know, for certain certain employees, the leave is some of it is paid, and I know other institutions, even in peds, even with, you know, the AAP policy statements on breastfeeding, and, you know, all of the anticipatory guidance we're giving our patients on how important breastfeeding is, it's not happening. You know, I know many female physicians who haven't, and that's just breastfeeding. That's not, you know, deciding to actually have the baby. So I wish I could say that I knew of one specialty that was, you know, embracing and supportive and tolerant. But I think it's highly institution, department, and division specific.
I think it is going to require more women in leadership positions, right? New York City Council just had its first Black female leader, and she has a female majority, and they have just passed their first bills for healthcare and bills pertaining to women. So it took like an all-female majority of the council to actually pass things that were favorable for women. So I don't want to say that that's what's going to be required, but I certainly, you know, in spaces that I'm in, lend my voice to that effect. And I think that the more of us who do that, then hopefully things will change. But, you know, medicine is still a specialty that eats its young. I mean, that's what they used to say, and we have to move past that.
I do think that procedural fields are perhaps, just with respect to getting called in kind of at any moment. I do think that is coming from a non-procedural field. I do think that that probably is a difference in, if people were looking for specific things around fields, around specialties.
And also to echo that, I think, if you're interested in leadership, a lot of leadership meetings are at times where there is no childcare, right? So at 7 a.m. or, 6, 7, 8 o'clock at night. And that becomes problematic as well.
Right. It's not as bad as when school meetings are at like 10 a.m.
Right.
I mean, there's nothing that annoys me more than that particular thing.
Totally remember that.
So a few more. What is one thing you all wish you knew before starting a career as a woman in medicine?
I'm going to say nothing because I think if I knew it, there's no way I would do that.
I was thinking the opposite. I was thinking like maybe the difference in pay, because that for me was very eye-opening. And I don't know what I would have done with that data. Like I had no plan B. Maybe I would have negotiated better. I don't know.
I don't know. Maybe I think maybe I probably just needed to be told, like, you can do this. Like, this will be okay. I think I felt like each time, like, oh my God, I'm happy I got into med school. Oh my God, I'm glad I matched.
And we just have a few more minutes, so I'm just going to ask one last question, which is, what have we not asked you between myself and the audience tonight that you would like our audience to hear about your either experience, this topic, you name it? If there's one sort of last sort of parting closing thoughts that you would like to share.
I think for me, it would be, I think the thing that hasn't been asked is, would I do it again? And my answer is wholeheartedly yes. I think that, as mentioned, I think, women can succeed in medicine if they have support. And if they feel like people, if they feel like they have a seat at the table or a voice. And I've been blessed to have that in my academic career. And so I think that I just want to emphasize the value of giving women a voice, because I think that as we've all mentioned, I think society has to change. I think medicine has to change. That change isn't going to happen if no one's listening to you or if you're not in the meeting.
Mm-hmm.
I think for me, it's really that I have been able to marry my professional life with my personal passion and interests. And it all kind of came together in this world of OBGYN, go figure. I didn't mention, but when I was at Brown, I was a women's peer counselor. Who knew way back when that, I would end up being an OBGYN. But I found this, I was looking for a picture on my phone because I found this schematic of something. It's called Ikigai, and it's what you love doing, what the world needs, what you can be paid for, and what you are good at. And ironically, it all came together.
OBGYN.
Ikigai, yeah. So, yeah.
Yeah, I've used that. It's like a nice little Venn diagram, and the one in the middle is your sweet spot. But yeah.
I found it.
That's excellent.
Any last thoughts from you, Dr. Parkes?
I guess I feel that I've sort of said them, but I guess just I'm gonna stick with my optimism because I do think it is hard out there in multitude of ways, having to do with medicine, having to do with the world. But I do think the young people going into medicine right now are going in for the right reasons, and we need to support them and allow them to have a seat at the table and have their voice be centered. And I think we're getting there. We're getting there.
Great. So with that, on behalf of the Pembroke Center, the Center's Advisory Council, and our program committee, I want to extend a tremendous thanks to Drs. Holland, Parkes, and Wilcox, and also Chevalier Luthra for doing these excellent questions that I hope I did justice with by asking them. And also to thank you, everyone who's attending, for taking the time to be here tonight. We hope that we'll see you again at a future Friends of the Pembroke Center event.